Good afternoon, everyone. Welcome to all of our health and social care and voluntary sector colleagues on this great webinar about a very, very important subject. We have a fantastic opportunity as we emerge from the pandemic, and hopefully we will continue to emerge, to reset and rethink about our children's and young people's services and how we can redesign them, learning from the lessons that we have gone through during the pandemic that has accelerated so much change and brought about a huge amount of integrated collaboration between different organizations and sectors. So the question we're going to ask is, what should integrated health and social care system look like that will really affect children and young people in a very positive way, particularly around their mental health, that can lead to better support and outcomes for all of them? And we're going to hear from some system leaders in the NHS, and we're going to hear from leaders outside of the NHS and the voluntary sector as well, from Bernardo's, and we're going to gain knowledge and insights about what there is to learn about integrated mental health models of innovation and excellence as we go forward. I'm not going to say a lot. I've just got one or two things that I want to emphasize. I think we need to understand that children and young people are our present, not just our future. We often talk about them as our future, but they're part of society, part of families, part of all of us right now and here. So our failure to invest in their future will actually cost the system long term. Quite apart from the human cost involved, it will cost money and resources that simply won't be there as we move forward. I'm very aware of the underinvestment in children and young people's services over many years, and even more so in prevention and early intervention for children and young people, despite all the evidence that says that there is huge benefit from doing it. Things have started to improve, but they've got an awfully long way to go. And so what we need is new and better models that are less medically orientated, less medically modeled, and are much more holistic and based in the community, so that we don't take children and young people away from their families and their social networks, so that we really get them integrated back in where they can really thrive. And organizations like iThrive have been doing great work around this, and we want to explore this whole area a little bit more this afternoon, and we've got some great speakers to hear from. So without further ado, we're going to press straight on with our first speaker. I'm not going to introduce people in detail. You have all of their bios in the documents that you've got available to you under files at the right-hand side of your screen. So I'm just going to say who they are, where they're from, and then let them speak. So first of all, we're going to hear about a vision for future mental health services for children and young people and families from Rickshawn Kapasi, Director of Health at Bernardo's. Rickshawn, great to have you with us.
Thank you very much, Phil, for the introduction. So can I move on to the next slide, please? Thank you. So Bernardo's is the largest children's charity, and we operate right across the UK. Our size and scope really gives us a breadth and depth of understanding for children and young people and their vulnerabilities. We've got 157 health services right across the country and 78 mental health services. Although many of our residential services are services that are supplying sort of employment skills and training to young people, also have a very positive impact on the mental health and well-being of children. We have a pulse on how children are feeling, what their needs are, and how families are coping through our quarterly practitioner surveys that we do across our 800 plus services. And one of the things that we realised very early on last year was that we were seeing a huge rise in mental health needs, so that by June 2020, 81% of our practitioners were supporting children and young people who had an increase in mental health needs as a result of COVID. Having this early insight into emerging needs really enabled us to respond at pace to meet needs. And we mobilised a national service called See Hear Respond in a matter of weeks in partnership with the Department of Education to meet this hidden need due to school and service closures. And we provided support and interventions to over 100,000 children, young people and families. And 66% of those we supported had mental health needs. Next slide, please. As Phil has already highlighted, the mental health system is facing huge challenges at the moment, and we've been aware of some of these challenges in Barnardo's well before the pandemic. And these challenges have both been laid bare and been exacerbated by the COVID pandemic. So, for example, we've seen that there have been huge increases in the number of young Black and minority ethnic carers experiencing grief, loss and bereavement. And also, in terms of Black, Asian and minority ethnic communities, there's been a disproportionate increase in people with eating disorders and also seeking help through suicidal thoughts as well. Next slide, please. The cost of getting this wrong is huge, both at a human and an economic level. And some of the statistics are really stark. So at the age of 11, those from the lowest income families are more than 4.5 times more likely to experience severe mental health problems. And we know that perinatal mental health is a huge cost to the system. But in terms of affecting a child, even pre-birth, it has a huge impact, both physically and in terms of mental health and well-being. Next slide, please. So this is why, in terms of our vision for health and well-being in Barnardo's, we really want to work with partners at the earliest point so that we can improve their health outcomes across their life course. And we believe that co-production is absolutely vital to this, and we need to listen to children and young people. And I just want to pause for a few moments so that we can hear the voices of children and young people who have received our mental health services over the last 12 months.
Barnardo's has continued to support me with my mental health by keeping in contact. This has allowed me to support my friends better as I feel supported myself.
Zoom meetings and online calls kept me sane, and this wouldn't have been possible if Barnardo's didn't provide me with a laptop.
The Penguins programme has helped me to develop a lot of independent skills and has motivated me to use these skills in the future and at home.
I used to be at home pretty much all the time, and talking with me has led me to meet other young carers and make loads of friends.
I am so grateful for the services from Barnardo's. It has made such a difference for me, especially through lockdown. Seeing Amy for a walk and a chat made things seem okay. She really understands and doesn't judge.
What I think is unique about Barnardo's is the relationship that children and young people have with staff. Staff ensure that children and young people feel truly listened to and heard.
I didn't have a bond with my brother, but we had a laugh and a giggle at the session on Zoom, which is a change. And that came from talking with Kirsty about what I wanted.
Barnardo's are always there with things to do, and the staff are there to guide and help you wherever you need it.
Thank you very much. So looking to the future then, in terms of creating better mental health and well-being, we feel it's essential that we move away from a deficit model where we're preventing mental health, ill health and crisis intervention and investing all of our resources in this area to moving on to well-being, where we're co-creating health, as Phil mentioned, at a local level with children and with communities. It's really important that we think about developing services that are not only child and family centred, but are also trauma informed and culturally competent. And in addressing the workforce crisis for the future, we really need to work together collectively across the system so that what we have is a continuum of roles that might be a volunteer at one end of the spectrum with clinical roles right at the other end. So can you move on, please? Thank you very much. In Barnardo's, we've had a lot of learning over the last 12 months and we've embedded that into our future vision. And we're aiming for resurgence rather than recovery. So that's a system that delivers better health outcomes for the next generation. And we want to very much work with our system partners to deliver that. And the 5 key elements that we think are really important for this are innovation, partnership working, long-term thinking and investment, evidence of impact from shared data and co-production. Over the last 12 months, we have accelerated the pace of digital use, but also digital technology development. And within Barnardo's, we have developed apps. We've also used web chats and forums that are web-based, and pivoted a lot of our services so that we're using Zoom, WhatsApp, FaceTime, etc. This has really enabled us to keep our services open, to reduce waiting times, and also to respond to the changing needs of children. But it hasn't been the right solution for everybody. We've become really aware of digital poverty among families, the needs of children with learning disabilities, and also privacy issues for young people too. And in the future, it's really important that we think about at a systems level, how can we develop safe, effective solutions so that we're not all working in silos and reinventing the wheel and really diluting the scarce resources that we've got. So we'd like to call on the government to develop an innovation fund with NHSX and other partners where we can really develop safe, effective solutions going forward. When we developed See Hear Respond, what was really inspiring about that relationship that we had with the Department of Education was that we shifted from a traditional transactional approach to commissioning to co-production and partnership working. So we developed a national solution that was very, very creative, where we used a range of one-to-one support to group work to social prescribing solutions. And we worked with 87 partners right across the system. And because of that, we delivered a much greater impact and reach as well. So 45% of our referrals out of the 100,000 children that we saw were from Black and Asian and minority ethnic communities, and 22% of children were from a whole range of children that had special educational needs and disabilities. And 88% of children, when we did our evaluation, found that the solutions and interventions had really been effective in relation to supporting their mental health and well-being, but also in relation to their loneliness and isolation that they were feeling. A lot of the services that you will hear from during this seminar will talk a lot about evidence and impact and co-production, but we have a real opportunity at the moment to think about co-production at a systems level as well as at a local place-based level. And in the forthcoming care review, the government has a great opportunity to look at co-production. Next slide, please, Rob. We are at quite a pivotal moment at the moment in the NHS, and it's a very exciting moment too, where we can create shared value and shared responsibility for really tackling the root causes of ill health. And we need to really think about how we can use integrated care systems going forward in the future to develop a new joint model of working and of care. Up to now, we've been rewiring the care system that we've already got and rewiring the house, but we have an opportunity to build a new house that's a joint house and that we can wire differently into the care pathways that really link with the realities of children's lives and the places that children go to first to get their support in terms of schools, youth clubs, social prescribing schemes and voluntary sector organisations that are their first port of call. And this is really, really important because we have one opportunity now to really get this right and work with each other. And no one agency can achieve this alone. And it's important that we really invest that resource upstream so that we don't have to build bridges downstream, and really achieve effective outcomes for children and young people that are sustainable in the future. Thank you.
Thank you, Rickshawn, for that summary of what Barnardo's has been doing as an example of how the voluntary sector can work very effectively with the NHS. Really appreciate that. Apologies, there seem to be some glitches for some people with the video and the audio there, and apologies if you didn't get it completely. It certainly didn't play at all for me, and apologies if I interrupted with a voiceover because I thought nobody could see it. We're going to hammer straight on. There will be some time for questions and answers at the end. Please put your questions in the chat function and we'll do our best to screen those and see if we can come up with questions that we can put to the panel at the end of this. So I'm going to press straight on to somebody who's no stranger to most of us, and that's Claire Murdoch, who's the National Mental Health Director for NHS England. She wants to talk to us about the strategic mental health priorities for integrated care systems. So Claire, I'm going to hand straight over to you with no more ado. We're welcome.
Claire, I think you're on mute.
On mute. Does that unmute? I'm unmuted now. Sorry about that. Well, I just welcomed you all and said what a pleasure it was to be talking about such an important issue, i.e. the mental health of our children and young people. And I love what Phil said at the beginning about they're not our future, they're our present. And also our future. So just a few things, because I know we've got lots of speakers and I'm happy to take questions later. So we all acknowledge, don't we, that before the pandemic, if we can remember life pre-COVID, that it is, there was a pre-existing treatment gap for children and young people in terms of accessing specialist mental health services. And we had the 5-year forward view and then the long-term plan that has set about trying to close that treatment gap, making it easier to access services when people want and need them, as opposed to long waiting times. We'll come back to that in a minute. What's absolutely clear is we don't want to medicalise and over-medicalise mental health problems, but we do want to make it easy for youngsters to see specialists when they need to. What's also absolutely clear is there is incredible experience in other sectors, which if we work together, we can really apply to the great benefit of our young, and certainly our third sector colleagues, education, social care, community groups, parents and adults, and young people themselves. So there's lots of assets that if we're to prevent escalation up to specialist services or make access easier to specialist services, we really do need to do that in partnership. So I wanted to say that post-COVID, well, we're not post-COVID, post the first really dreadful year of this pandemic, and who knows when we'll be post-COVID, I think we've all learned a great deal, and certainly we've seen increasing demand. Referrals tailed off in the early months of the pandemic, and to some extent that was to be expected for a range of reasons, and evidence internationally is that when societies have a great shock, very often the first response is to retrench to the safety of home and concentrate on the basics, and that mental health the mental health impacts come later. We actually saw throughout the summer of last year and into the autumn a very significant resurgence of referrals of children and young people service into us. We were referrals into the NHS. We were hugely concerned that during the pandemic, obviously we'd seen school closures, though we know that education and teachers and others were doing a great deal to reach out to their students. Nonetheless, we know that there was a big disruption to daily life. We saw a big resurgence in referrals, and we're now back up to pre-pandemic levels. Certainly, we are seeing increased demand for eating disorder services for our young, but also services around anxiety, depression, OCD and other things. Can I go to my first slide, please? So just very briefly, I'm not going to read from the slide to you, but just to very briefly recap on what the long-term commitments were. The long-term plan runs from, entering the third year of a 5-year plan now. So it runs to 23, 24. And we're really, really clear about some of what we need to achieve in partnership. And you can see here that we had wanted to increase access to services, but because when we began the 5-year forward view, we think we were treating 1 in 4 youngsters that would benefit from specialist intervention. We want to get that up to at least 1 in 3. Anyway, we've moved to crisis services across the country in terms of either 111 or a local crisis number for young children and young people, and that's 7 days a week. And thanks to colleagues who were part of making sure that the NHS could offer that. We know many of our charity colleagues and others also offer helplines, but it's the first time that the NHS across the country and mental health providers has offered that. We've really wanted to work with providers of services to introduce what we're calling provider collaboratives and new models of care. We want to change the distribution of what we spend on children and young people's mental health, so that we're spending more in prevention, early intervention, different models of care, particularly, for example, in schools, the mental health support teams in schools. And we want to spend less on tier 4 inpatient services far from home if we can. But you can only do that if you're investing heavily in local alternatives where you're intervening sooner. So the provider collaboratives are hugely important to that. There are some smaller investments that we're making which are nonetheless pivotal in, for example, youth and justice and particular areas. I don't intend to go through all of that. I've referenced the mental health support teams in schools. This is really exciting because I think that the support we give to children and young people in schools and colleges of further education is incredibly important, because if you do it well, you bring together primary care parents, the young person, their teachers and education, and the NHS and social care. So school is where most young people live their lives most. And so we've got an ambition and a really clear granular plan that's funded to be covering 20 to 25% of the country by 2022. We're ahead of trajectory. We're training thousands of new therapists and so on and so forth. And we're working with third sector and other colleagues on that. We've been piloting what would it take to have a 4-week access and waiting time standard for child and adolescent services. We've massively migrated to digital therapies and online. And as our Bernardo speaker was saying, we've all learned so much about how to provide care, treatment, therapy, support, advice digitally. And we know that many young people prefer that. And we're seeing a very, very considerable investment in eating disorder services everywhere. There's a lot to do, but we know we've made progress. Can we just go to the next slide, please? Certainly when I'm on a long walk and perhaps going up Scarfell Pike or somewhere else, going up, it's tiring, and you can only see still how far you are from the pinnacle. It does us well to sometimes look back and think about what we have achieved. And this slide here just sets out some of the things that we've achieved in recent years. We know in recent years we've seen a doubling of the child and adolescent mental health workforce. We've got 180 mental health support teams in schools up and running, but we've got 200 more where we've got the therapists in training now that are coming on stream. We didn't have child and adolescent eating disorder services everywhere across the country. We now do. We set up 72 of those services. And I've talked about crisis, and I've talked about our desire actually to shift funding as much as possible from beds. And where perhaps young people do need a bed for a short period of time, could we spend some of that inpatient hospital bed money on more like local respite crash pad services, where we wrap the system around the child in the local place or young person and get them home much sooner? You can see here, if we can go to the next slide on investment, please, that some very significant new funds are flowing to the front line to power all of this plan. And certainly we hope to be spending an additional nearly £1 billion recurrently through the long-term plan by 23-24 in the sorts of areas that I've just been discussing with you. In addition to the long-term plan funding, it's true that we had extra money for children and young people this year through the spending review, where government could see we had an extra 79 million for children and young people this year, where government could see what the impacts of COVID had been. And if we can just go to the next slide, please. Sorry to rush, but I know Phil will tell me to stop any minute now. The 79 million that I just referenced, which is on top of the long-term plan and transformation monies, was part of a 500 million bundle from government for this year in respect of the COVID impacts. And that tells you a little bit about what it's for. But you can see there the 79 million at the bottom of those bullet points that I mentioned earlier that are specifically about children and young people's mental health services. It's true to say that of the money on the previous slide and this 79 million, so the kind of 900 million plus, that an awful lot of that delivery will be done directly by NHS trusts and specialist services, but an awful lot of it will be done by third sector and other partners working in partnership. So this isn't all NHS money spent on NHS services. Can we go to the go to the next slide and then go on to the next slide, please, because I'm worried about time. Thank you very much. I just want to acknowledge that, of course, as ever, not only are we moving to the next stage of COVID recovery or restoration, but we are in the NHS moving to a new system, a new structure around integrated care systems. Now, if we really optimise that opportunity, the whole point of integrated care systems is to work in a much more joined up way in a local area across all the partners and agencies I mentioned earlier, and to really target your different populations within a place or a footprint. And we know that COVID has laid bare what we knew already, some of the pre-existing inequalities, and that certain of our populations or our children and young people are disproportionately affected by mental ill health. So we are working very closely in the new developing system architecture to make sure that learning disability, autism and mental health is absolutely seen as a fundamental part of all ICSs together with the partners. I don't see how you get to have good good physical health or health and well-being without good mental health. Can we please go on to my last slide? You'll be pleased to hear, Phil. So there are also some other great resources that either we have been supporting the development of, others have been leading the development of. We know that a lot of our charity colleagues, we know that Public Health England, we know that Education have got some fabulous resources out there. I'd quite like to test with the expert colleagues on the line a view I have about how we pitch the narrative around children and young people right now over the next year, 2 and 3. We've clearly got this huge increase in demand and investment. We had the pre-existing gap to fill. I'm not complacent at all about the urgency of all of this, but I think we need to be really responsible about our narrative. I've been quite upset about narratives of tsunamis and we've ruined the lives of a generation, or COVID has. No, can we switch some of that narrative to what incredible and amazing resilience so many of our youth have, what amazing lessons so many of them will have learned through this appalling time, what incredible assets they themselves have. And certainly I've never heard society talk more about mental health. So can we change some of that narrative to we're all a lot more aware now than we were? Can wider society step up and play a greater part, whether that's industry and others, in not pumping harmful messages about idealized body images, diet lollipops, you name it? Can we all just take this opportunity to say we will be a better society for our young, notwithstanding for a minute that I'm not at all complacent about what we're trying to achieve through the long-term plan and what needs to be done? Thank you for listening to me.
Claire, thank you so much. That was a fabulous summary of where we're at, and really very, very easy to follow, and thank you very much for that. I hope you'll be able to stay around for the questions and answers a bit later on. We're now going to go straight on to hear about some innovative work in Birmingham between the National Health Service and Barnardo's. It's an integrated CAMS model called Solar, and we've got Liam Lawson, who is Solar Hub Manager, and Libby Thompson, who is a Children's Services Manager for Barnardo's. Straight over to both of you. You're very welcome.
Well, thank you very much. I'd get in trouble if I didn't correct you that we're in Solihull, not in Birmingham. So my name's Liam Lawton, I'm Birmingham Solihull Mental Health Foundation Trust, Solar Hub Manager.
And I'm Libby Thompson, and I'm the Children's Service Manager for the Barnardo's half of the partnership of the Solar Project.
Wonderful, thank you. And you can see from the first thing on the slides is we've heard a lot about that integration. Solar is there, very, very big. The partners are along the bottom, so Birmingham Solihull Mental Health Foundation Trust, Barnardo's, and also West Midlands, and it's very much a joined up and partnership approach that we're here to talk to you about today. Wonderful. So I won't read from the slide, but Solar was started in 2015, as we said, as a different approach to CAMS services. So the name Solar itself came from a group of children and young people in the local area who, when the service was being recommissioned, were really engaged in the process and said, we don't want our services to be called CAMS. We don't like child and adolescent mental health services as a label. We don't like the stigma attached to mental health in accessing support for our emotional being and mental health. And we don't want it to be fixed on mental illness. We don't want to be thinking about that deficit model. As we talked about earlier, what we want to think about is light and energy and positivity and emotional well-being. So children and people themselves came up with the name Solar. It doesn't stand for anything in terms of Solihull, but it does have that focus on re-energising and re-infusing, and that positive energy is what we wanted it to come from. So in 2015, Birmingham Solihull Mental Health Trust, which is the largest mental health NHS trust in the country, and Barnardo's, which is the largest children's charity in the country, came together and said, we can deliver a different approach to emotional being mental health services. And on paper, what a wonderful collaboration we had in terms of the skills and expertise that would be brought both in mental health and in supporting children and young people. It has been a journey, but we cover that 0 to 19 age group, and I'm very, very proud of the service that we've got. So just to talk a little bit about the traditional CAMS setup and how we are different to that. The traditional CAMS sits in that pyramid structure. So your tier 4 services, your specialist psychiatric wards for children and people needing inpatient care for their own safety and the safety of others, in terms of their mental health being at such a point that they need that specialist and ongoing treatment and supervision is provided across the country. Your traditional CAMS service, your traditional NHS medical model CAMS, is that tier 3 team of multidisciplinary teams made up of medical colleagues who support with the more moderate, severe and enduring mental health difficulties. And then you have a wealth of services at this specialist or targeted support at tier 2. So you have voluntary sector organisations, local authority organisations, some health providers who provide a raft of emotional being mental health services for children and people. But what we often find is children and people being told they're too poorly to access one of these services, or not poorly enough to access another, or have a specialist need in one particular area, which means they need a referral onto that service. And we see young people moving across the system, facing barriers and having to retell their stories and ask for support time and time again from different providers, fill in a different referral form, phone a different telephone number, turn up to a different building, and face real challenges in accessing services for them, for themselves. At Tier 1, you have that universal offer, GPs, schools and our colleagues there in school nursing, etc., and how difficult for them as well to navigate that system when as adults we've created barriers and challenges for young people to access the right service at the right time, and for them to give the appropriate advice when there are so many services and different bits to choose from. So in 2015, we were set up differently. So our model mapped against this. Next slide, please. Wonderful, thank you. Very much shows the difference in how we approach things. So whilst absolutely we'll still need those specialist inpatient beds, and we do have some young people who require that specialist intervention and do end up in inpatient. Of course, we rely on our colleagues in the primary care services in terms of those GPs and universal services. The SOLA model maps against all of everything in between. So we have our dedicated crisis and home treatment team, down to we also coordinate all of the universal offer of Solihull's parenting programmes, accessible by all families across the Solihull borough, and everything that is in between that. Idea being, for a challenging person or family in Solihull, you come into one service, you tell your story once, you access the right level of support, whatever it is, and however that's best provided. So for a challenging person and family, you don't know if you're coming in and talking to someone who's employed by Bernardo's, someone who's employed by the Trust, someone who's employed by West Midlands. You fill in one referral form, your notes are held on one central system where everyone in that team can access them, and you have a smooth and seamless journey and response to your emotional being and mental health needs, whatever the severity or threshold of that is, and you're supported at that earliest point by the right team and right people.
So one of the really good things about being able to incorporate all of those different teams within one service is that we have the mixture of different practitioners that run with that as well. So this is just kind of a breakdown of the different teams that we have within the SOLA service. And within those teams, you cover your normal psychologists, family therapists, psychiatrists, CPNs that you get within your secondary care CAM services. But additionally, we have counsellors and prime mental health workers and wellbeing practitioners, and we work with link workers linking into our youth offending service, into Autism West Midlands, into our GP practices as well. We have link services in. We also work with volunteers within SOLA, and we have students as well. So by bringing it all into one service, all of those practitioners are available for each other to learn from in an MDT capacity, but also so that children and young people coming into SOLA get all of that knowledge from just one service, and they don't have to move around to achieve all of the knowledge that all of those people have, which is really useful.
Thank you. In terms of accessing the service, so one of the things that we were set up to do was absolutely about providing that holistic offer and that more robust offer. It was also about increasing accessibility to mental health services, and children and people told us that again, time and time again, in terms of when they want support, they want it to be easily accessible. So as a service, we accept self-referrals, so children and people themselves can directly come into us, ask us for advice, guidance, support, ask us for an assessment or intervention or treatment. We accept referrals from parents and carers or family members as well. So a young person can tell their mum, dad, cousin, auntie, grandparent, whoever it is in their network that they feel like they need support, and we would accept those referrals on behalf of the young person, as well as, of course, traditionally taking those professional referrals from our colleagues in school nursing or educational psychology or GPs or social workers. It's all about making sure that those young people are seen and have as quick a response to services as we can. I think traditionally, and the sort of story that I always give is we had young people in the past, prior to accepting self-referrals, who would notice that things were a little bit difficult, who would perhaps notice that they're not feeling themselves, they were low in mood, they were highly anxious, they felt like they needed some additional support. They might tell someone at school, as an example. Their teacher might talk to them about it, someone that they trust. That teacher would then say, oh, as a health service, it might be best to book an appointment with your GP, because to access CAMS, GPs might know a little bit more than what we do in education. So go away and book an appointment with your GP. That young person would go away and book an appointment with a GP, might wait a couple of weeks for that appointment. They'd go to the GP, they'd tell the story again that they've already shared with someone at school. We then typically, we know how pressed GPs are, would get a one-line referral, please see Johnny, he's anxious. And that's what we get from the end of that consultation. That letter might take a little while to get to us. And when we receive that as a service, not only do we not really know how to help or support Johnny because we've got such limited information, but we're also very aware that he's told his story 2 times already and has been waiting for the support now for 4 or 6 weeks by the time he's plucked up the courage to ask for help and support. We then traditionally would perhaps be able to offer an appointment, but based on such limited information, we might not be able to. But if we do, he comes into us and he's waited another, say, 4 weeks for an assessment appointment with us as a service. Now, little Johnny, if he knows about it, can refer himself into service. He can acknowledge that he's feeling difficult and that we'd like help and support. And if he knows about us and if we've done our job well enough in terms of raising the awareness of what we do locally, he can fill in a self-referral form or he can phone us up himself and ask for that support, which relieves the pressure on the system in terms of our colleagues in primary care and GPs, and means that when little Johnny does contact us, he tells us exactly what he's feeling and thinking, exactly how long he's been experiencing it for, exactly what's going on for him and what he would like to be different, which helps us to identify the right person within that huge multidisciplinary team we've got to provide the right support at the right time, so we get those needs better. Johnny's also much more likely, and what we found is he's going to turn up to his appointment, whereas when we get a one-line referral from a GP and they're not engaged in the process, he may well not come. He gets a letter from us saying, please come to your appointment at Surrey, and he doesn't know who we are or what we do, so he might not attend that appointment. Whereas when young people have referred themselves in for support, what we see is much higher attendance rates and much better outcomes for those young people.
So I think we wanted to kind of talk about the impact that partnership working can have. And one of the ways that we wanted to do this was kind of just pulling some of the charts which are in the most recent NHS benchmarking report. So this is where we're compared against other mental health services that are also included in this report. Do you want to talk about this one?
Yeah, so we are the darker coloured bar. So this is looking at the average waiting times from a referral into a mental health service to the first appointment, so to that assessment appointment. What you can see there, the line across is the average, and you can see that we are towards the lower end in terms of the average referral time to a first appointment being so brief. Again, that's achieved by the fact that we've got so many colleagues and disciplines within the same system and within that solo model of working, means that we've got more staff than perhaps traditional CAMS services have. We're not signposting out, and we can rely on the right skills, right time. And the next one looks at numbers of contacts. So per 100,000 of the population, how many children and people are accessing support for their emotional being and mental health. And again, you can see that dark green line far and above the average. By having that integrated collaborative model, we end up with seeing far more children and people than perhaps other CAMS services can or have capacity to.
So some of the final thoughts, it's thinking about integrating services through strong collaborative working, using your statutory, your independent and your voluntary community sectors to achieve some of the things we've spoken about in this. It's that easier access, it's telling the story, less time for young people, and them having access to the right professional at the right time. And that can make so much of a difference to a young person, being able to not knowing what's happening behind the scenes, not being told you need to refer to this person, this person, this person, but just being referred into a service once and then having those conversations happen and for you to be able to access the right support.
Absolutely. Conscious it feels common, which means we're running out of time. And obviously the points are there, but I think my final point would be we as adults sometimes create these barriers for children and people, and actually the take-home message, we as system leaders and as services are the people who can remove those barriers as well, and there are ways in which we can do that as long as we work together.
Thank you.
Thank you both. That was very interesting to hear about and exciting about the concept of that integration. And I think it's the kind of thing we need to be doing to really transform our children and young people's services. There are questions coming in. Don't forget to put your questions in if you have them. We're going to move straight on to hear from another couple of people who are going to talk about Stronger Together, some lessons from the Surrey Wellbeing Partnership. So we've got Lucy Ivankovic, Assistant Director for Children's Services in Barnardo's, and Dr. Anne Kenny, Independent Chair of Surrey Wellbeing Partnership. So straight over to both of you.
So afternoon to you all. I'm Lucy Ivankovic. I'm an Assistant Director for Children's Services with Barnardo's across Surrey and Sussex, and I'm going to be talking to you today about the Surrey Wellbeing Partnership, of which we're a part. The Surrey Wellbeing Partnership is a group of third sector charities that have got together in Surrey to work with each other, and we were aiming to submit for the Emotional Health and Wellbeing tender within Surrey. So there's 12 charities altogether. The only two that are national are the National Autistic Society and Barnardo's, but we've come together to work really locally to meet the needs of children in Surrey. And we came together probably about 18 months ago with a really good, strong shared vision of having the third sector as an equal partner in emotional health and wellbeing for children across Surrey. And we really wanted to make young people at the heart of our decision making. And we've created a really strengths-based approach to working together, recognising our own strengths and really now working much more in collaboration rather than competition. There have been, prior to us coming together as a wellbeing partnership, we were in competition with each other, and this partnership has taken all that away and we've come back together much stronger together to create services, and we've developed really strong trust with each other and we've created a shared value base. So the difference that the partnership is making in Surrey has been quite considerable. So by being a strengths-focused organisation, we've enabled all of the different charities to work to their best, and therefore we've created this really rather wide range of services and opportunities for children and young people across Surrey who have got emotional health and wellbeing issues. So we've created new teams like the Community Wellbeings team, we've created workshops, counselling, advocacy. We've got a whole range of schools interventions, parenting support, theatre groups and mentoring. And the idea of the partnership was really to come together to create local delivery by local specialists across the county. The focus of the early intervention was really to move away from children and young people having to go to their GPs, get referred into a central SPA and then wait 2 years for intervention. The idea is that we will provide intervention in a broad range of methodology to people when they want it, when they need it, in their communities, and before they get really, really poorly. So they have the early intervention at a time when they need it, which reduces significantly the need for clinical interventions later. So there's no waiting lists for them. And the contract that we won in partnership with Surrey and Borders NHS Trust was a large contract, but actually coming together to create the Wellbeing Partnership, the third sector have now got £4.5 million worth of business in that for 7 years. It's actually 7 to 10 years because it's 7 plus 3. And so the idea that each year the commitment to early intervention will grow and therefore the need for clinical intervention will reduce. So year on year the funding is moving over to the Surrey Wellbeing Partnership to create more community-based support for early on intervention for children and young people. So what I also want to talk to you about is what Barnardo's is offering within the early intervention arena within the Surrey Wellbeing Partnership. So we are offering community wellbeing teams with 4 other providers. So we're providing services across the whole of the county, and Barnardo's is providing those across 4 different boroughs. We're the largest provider within that, with 11 staff across 4 different boroughs. We're also providing support to children with to schools with ADHD concerns, so we're providing training for that, and we're also providing support for parents. The support for parents isn't coming online until October, but that's the idea. The idea of that is enabling parents to be strong and the best parents they can possibly be to their children, their best support, their best protective factor. And we've found that parents who are really concerned about their children's well-being tend to have their own anxiety and worry about that, and therefore don't have anywhere to go. So this support is an aim simply to support parents to be able to be the best protective factor. However, Barnardo's are also part of the Surrey Alliance, and therefore within the Surrey Alliance we're providing a neurodevelopmental pathway, and we're providing ADHD services to parents and out-of-hours support to parents and support in schools, celebrating children with ADHD in schools who are quite often excluded, and we want to celebrate their very personality, really, to give them more confidence. So the last slide shows the Alliance. So you can see that the Surrey Wellbeing Partnership are in green, and we're part of the Alliance. We're one of the main partners of the Alliance, which places the voluntary sector at the heart of the decision making as an equal partner, which is really, really profound and changed actually the transformation delivery of services across Surrey. There's also then Barnardo's and National Autistic Society and Learning Spaces, the voluntary sector, are also partners in their own right. And that's where I've just gone through the neurodevelopmental work. But I'm going to pass you on now to Anne Kenny, who is the independent chair of the Surrey Wellbeing Partnership, to talk about the future and where we're going as a partnership.
Hello, my name is Anne Kenny and I'm the independent chair of the Surrey Wellbeing Partnership. So, as Lucy said, a number of organisations came together to join the Wellbeing Partnership in order to tender for this particular piece of commissioning. Our ambition is that we will be part of a broader alliance across Surrey. So we represent the Third Sector Consortium as part of that alliance, and our ambition is to transform the emotional wellbeing and mental health services in Surrey. Our mission as a partnership is to take a lead in the prevention and early intervention in the approach, and over time reduce the need for clinical interventions, and we'll do this by building resilient communities and changing lives. The piece of work that we're doing across the Alliance is embedding the Thrive model, which really places children's needs at the heart of everything we do, and is needs-led rather than diagnosis-led. So not only are we bringing many partners together for this piece of work, but we're also changing the approach across the system as well. This slide just gives you a pictorial overview of where Surrey Wellbeing Partnership is as we sit on the Alliance board and who some of our partners are. So I'll go into some detail about that in a minute, but also the offer that we have among our 12, 13 partners in the partnership in terms of working directly with children and young people and families through counselling, or through our community activity groups in the community through a number of our partners, so drop-in cafe sports groups, issue-based groups, working in schools in a variety of ways, with one-to-one with young people, but also with staff, parents and governors. Also supporting at the single point of access and developing that more into an access and advice point, so that actually we can signpost people to self-help, as well as the various different types of services that we'll offer across the whole partnership, and also working with our health colleagues in various health settings. And so some of our partners are providing one or more specialist services in these areas, and some of our partners are banding together to provide services across the piece, some of which I think Lucy went through. So what we have, though, is an alliance approach, and so that's a shared approach to delivering the work. So around our alliance steering board, we have our 2 NHS partners. We have Surrey Wellbeing Partnership, which represents 12, 13 members, and we also have our neurodevelopmental specialists from the Voluntary Centre, National Autistic Society, Barnardo's and Learning Space. But we also sit on that alliance board with our commissioners who commission the piece. And the commissioning had a different approach in Surrey this time. So Surrey County Council and Surrey Heartland CCGs banded together and did a long piece of commissioning over 7 years, as I think Lucy mentioned. And that allows us to really try something new and also to embed things over time and iterate and improve. So we have a shared responsibility for delivering this, and a whole range of stakeholders, from the services that I just showed you to our Alliance board that we're working together with. So I just pop back here. There's the opportunity to change things in Surrey is huge, and certainly the commitment from all these different partners is unquestionable. We really want to build a service that puts children at the centre, but in doing this, there's various challenges with working with so many stakeholders. These are some of the challenges, and I'll just mention a couple. But as you can imagine, meshing together the voluntary sector with the health service and commissioners, some of whom have very different perspective on things. There is an ambition to work together, but we have to work through some of the discrepancies or differences of perspective that we have. Putting in a whole new approach through the Thrive model and putting that across the system. Mobilising new services whilst also tackling a legacy backlog and the subsequent reputation that goes with that. Making sure we communicate all our changes with various stakeholders, and having done this with the background, of course, of the COVID-19 pandemic. What does the future hold for the partnership? Well, we're in our infancy. We've only just started year 1 of a 7-year contract. We want to establish the full offer across the partnership as quickly as we can. We want to demonstrate the impact of the approach to early intervention and the difference it can make to children and young people. We want to learn, so we want to iterate, improve and expand the offer to cover any gaps in our services that we might have, to reach hard to reach groups or any unmet need, and to also encourage different services to come into our partnership through our associate membership route, maybe more horticultural based or maybe animal therapy based, different types of services that children, young people and families could use. And also to play a key role in the drive for system change across Surrey. Some of the lessons that we have learned is that if we'd had more time, I think we would have put far more time into some of the conversations before mobilising services. We did a lot of work around the partnership in terms of relationship building and trust building, which Lucy mentioned. But I think as an alliance as well, we're putting in this work now around partnership working, culture, behaviours and attitudes, digital and data piece. And also just time, capacities and resources and the differences we have across the partnership in terms of what we have to bring to the table. And so that's where we're really putting in some time now, as well as we're mobilising to get through those. But we really have a good ambition to transform services, and we do believe that we are stronger together. Thank you.
Phil, you're on mute.
Sorry, thank you very much for that. That was really good. And we'll come back to ask some questions in a little while when we've had the remaining presentation. We're going to go straight on to Sarah Crawley, who's Director of Bernardo's in Wales and the Southwest. She's going to talk about working in schools to reach the most vulnerable children and lessons from the Swindon Mental Health Support Team model. So Sarah, straight over to you.
Thank you, guys. Thanks for having me. So I'm going to give you a bit of an overview, as I said, about the mental health support team in Swindon. But if you guys do want more information and more in-depth information, I'm sure we can provide it. We've got many presentations that we'll be able to send out to you with more in-depth information. And as you saw earlier, this fits really nicely into the bottom section, as it was referenced by Claire in the long-term plan for children and young people's mental health. So what I'm going to cover is an overview of Bernardo's mental health support teams and our position there, the Swindon Trailblazer, but also lessons learned and what more we could do. And some of the factors of what more we could do have actually been referenced in the previous 2 presentations. So we're always evolving and trying to change our model to adapt to the needs of children and young people. So in terms of Bernardo's, we are the largest children's charity in the UK, and we do have a UK-wide footprint. What you'll see here is our 78 mental health and wellbeing services across the areas of England. And what you'll also see is our fantastic orange dots, which demonstrate the mental health and wellbeing services that we have in terms of the mental health support teams. So we have mental health support teams from Cumbria to Morecambe to North Solihull and through to Swindon and the Isle of Wight. So we at the moment have 6 of our mental health support teams. We are one of the only voluntary sector organisations to be delivering mental health support teams, and we're really grateful for that opportunity from our partners in clinical commissioning groups and elsewhere. So we have a very clear approach to it, one that is very dedicated to delivering against the needs and for the needs of children and young people. As was mentioned earlier by Claire, we try not to have a medicalised model. We try to have a social emotional model in which we support children and young people with their presenting needs, and we listen and learn from them themselves. We have a clear co-designed approach with commissioners, schools and other providers, and we work directly with children and young people to develop the services that we actually offer. What's the great thing about Barnardo's is our footprint. Not only do we have these mental health support teams and these mental health and wellbeing services across the UK, we also have other services that integrate with them. So that might be family wellbeing, it could be young carers, it could be children with disabilities. So not often are you left without any other response or assistance. So I've said that we have got a footprint right across the UK and obviously are running mental health support teams. This was just a slightly dated diagram now of the situation in Swindon when we first looked to create the Swindon Trailblazer in wave 1 of the mental health support team rollout. What you'll see is a really complicated picture of differently commissioned services. And what we wanted to be able to do as part of the clinical commissioning group's vision and our vision in Barnardo's, along with our partners who provided all these services, was to actually utilise the I Thrive model, again being mentioned in the previous presentation. It's looking at bringing a whole system together where the needs of the child and the young person are front and centre. So you'll see that the Trailblazer fits in there underneath the clinical commissioning group. It has added a much needed dimension in terms of schools and self-referrals, and it's added, I think, the whole school approach and really integrated education far more into the system that you see and you'll see now with all of the mental health support teams. I'd like to thank the Baines, Swindon and Wiltshire Clinical Commissioning Group for actually taking a punt on Barnardo's. We were one of the first wave mental health support teams, and I think I think we need to be brave, and I think we need to think differently, as this whole session shows, to actually really make the change that our children and young people need within our society. Again, this is a slightly dated slide, but I think it shows for you guys the journey that all of the mental health support teams have been on and the long-term plan for the NHS for mental health and young people. We started off in July 2018 with kind of wave 1 and the publication of the paper and the report. And we've gradually built up 3 teams of mental health support teams, which are made up of our education mental health practitioners. So we have 3 of those teams that all have managers. We also have an outreach team and we have a triage team. So it's very much an integrated set of people that are not pulled across into other things because we're part of a wider clinical offer. They're actually dedicated support in that mental health support team within Barnardo's. And we work together with colleagues in things like STEP and Splash, which are voluntary sector organisations, and they assist us in engaging children and young people. One of the early things we felt we should do, and we should do well, was to engage schools. This was a new experience for them. They were being asked to provide a whole school approach. They were being asked to accept and integrate education mental health practitioners. And so we spent a lot of time working with schools, getting them to understand the agenda, getting them to understand how their pupils would be interacted with, what benefit they would gain. We put guidelines together, we put workbooks, we had co-design workshops with schools and with children, young people and parents. And so we spent a lot of time doing the groundwork, and I think that's really important when you're implementing something new and you're asking people to change change what they feel and how they practice. We also did a lot of groundwork with our partners, and as you've seen, partnerships are key to this kind of work and successful outcomes. And so we spent quite a lot of time with CAMS provider, which was Oxford Health, with the Teenage and Adolescent Mental Health Service within the local authority, and others, to make sure that we had a thriving framework and system, as opposed to a disjointed and basically disinterested people struggling to get referrals. So we were part of the initial wave. We got 2.3 million from NHS England to implement this. We're now covering, or were covering, approximately 50% of the schools in Swindon, which is 41 schools. We're part of wave 4, so we hope to extend that. And our vision was very much a graduated response. Within the pupils, so they're outside of their lessons, before and after school, weekend provision. We included the outreach work. The outreach work isn't just about searching out children and young people and offering a sort of marketing approach. It's actually physical outreach when we can do it. Lockdown's obviously hampered that slightly, but we do go out to sports clubs. We've got a fantastic partnership with Swindon Football Club. We've got partnerships with other sports clubs. We've got partnerships with community groups, and we've run virtual youth clubs for age appropriate categories throughout the pandemic. And that's actually brought together people from across Swindon that wouldn't necessarily actually have met each other and supported each other. Another vital aspect is the no wrong door model. So we've adopted the I5 framework, where we have a shared language, we have shared systems change approach, and we have a shared understanding of needs of children and young people, and they can express those themselves in their way. So part of that was not just calling it a trailblazer. A Swindon trailblazer didn't really mean anything to children and young people. So we actually had a whole exercise where we've renamed it, and we're now called Project Me, which I think is fabulous. And we have our own logo on our own identity. And that was really important because NHS England have presented the mental health support team and trailblazer model. But we wanted to give ownership to the children and young people who it's part of, and to our partners. So moving on, what have we learnt? Oh, so much. The mental health support team model is quite different to some of our other Barnardo services. So the structure is quite different, of having 3 teams in one service area. But we also learned about co-production with schools and with children and young people, that's so important. As I've said, it is the right starting point. We've also continued to engage them throughout with surveys, with feedback, with understanding where they're at and what they're experiencing, and whether we're actually providing the right service in the right way. I think with the waves that we've gone through, from wave 1 now into wave 4, it's enabled us to gradually build the service. So we've had a kind of test and learn approach. Test and learn for education mental health practitioners, onboarding them, test and learn with different schools, test and learn around safeguarding, CBT and practices, test and learn around our data and how we use our IAPTIS system to integrate that data with NHS England. You do have to go through a process with mental health support teams of training education mental health practitioners. We use Exeter University. There's a number of universities around the country. But it takes 12 months to actually, for an education mental health practitioner to be qualified. And then there's going through small amounts of case holding and then growing those and then becoming fully operational. So we always have to factor in that time lag and that training and support. Clinical supervision is vital, and the governance of that. So we have a clinical supervision matrix and a line management matrix that's working really well across the 3 teams and beyond. Whole school approach. Again, schools have really got on board with this. We've had incredible feedback. The schools saying it's changed the atmosphere in the school for certain pupils. It's meant that they can reintegrate back into school where they were struggling with anxiety, depression, low mood. because it is at that kind of tier 2 level. What we've been able to do is integrate them back in really keenly. And so they've had that personal touch. They've had their education mental health practitioner with them, and they've been able to go through that with the parents and with the family. So the one thing I would say, because I noticed Phil's come back in, is that we utilise the iThrive model, which you can see on the right-hand side, that's child and person-centred and needs-led. And we're trying to integrate that right across with an entire systems change for the whole of Swindon. That's not an easy exercise, and we're still on that journey. But what I wanted to draw your attention to was the diagram on the left. This is about the child being at the centre, having an education mental health practitioner that they trust and value, and they can work within the school and the whole wellbeing approach within the school. But what we can't forget is many of these children and young people will touch on social care. They will touch on CAMHS if their needs escalate and they have to go into a health environment. But what I think is vital to this whole systems change and ethos is the family. The family environment is where the child spends a lot of their time other than outside of school. Many of the issues are coming from them as also from their parents. There are social, emotional, financial issues that are occurring within that family, physical health issues, mental health issues. So I believe the next step, I think, for mental health support teams is a broader family wellbeing approach, taking the learning from Solar and others and co-producing family wellbeing plans that really get to the heart of every child's needs, including those in their early years and including those with special educational needs and other requirements. So thank you. That's my presentation.
Okay, that's great. So we've had a number of questions in the chat, and I'll kind of start backwards. So one of the questions that we had from Jenny Cobley was, what happens when you encounter a child with serious mental health problems who needs referral to CAMHS? And I think that was to Sarah from the last presentation.
No, that's a good point. And as I said, so there'll be escalation to CAMHS through referrals through us or through the school. So there will be escalations to CAMHS. They don't necessarily get a prioritised service, but there's definitely a prioritised assessment and understanding. Yeah.
Okay, thank you. And then a slightly broader question, I think, to any of the speakers really, and that is, how might children and young people and their families and carers truly co-produce integrated services? Have you got any examples from things that have worked really well? Oh, Phil is back now. Are you going to take over from me, Phil?
That's fine. We had a very brief power cut and my PC just went blank and I've had to log back in, so I apologise, everybody. What questions have you asked?
So I asked a question to Sarah, and I've asked another one around examples of truly integrating health and social care services. And I know there were quite a few questions for Claire as well around her presentation. So I'll let you take over, Phil.
Okay, we will do that. There were quite a few around schools, and I want to put those all together and put them to the panel, if that's all right. One person, Carol from Northern Ireland, who season for gradation there, was asking about before school support, early years, nurseries, preschools, and childminders. Somebody else was asking about is Place to Be involved in the plans for mental health schools teams or support teams, and will their trained counsellors be able to work in schools as part of MHSTs? That's a question for Claire. Another person was saying that actually school pupils need much more than just the simple health services, that often they get more help from social activities like sport and football and so on. And I was also asking whether more schools shouldn't be trained in trauma-informed approach and to avoid exclusion of pupils. Another person was asking how sports clubs can be brought into the picture much more. So a number of questions around schools. Claire, I'll come to you first, and then somebody else might want to add on to some of those things.
Thank you. Oops, I've turned my camera off, but hopefully there we are.
Much nicer
Camera
to
and
see you.
microphone. Yeah, there. Well, mixed views on that, no doubt. But yeah, I mean, to be clear, I think the whole school approach that was mentioned earlier is absolutely required for great emotional, psychological health and well-being. So instilling in our young at a very early age the great benefit of exercise. There was a question about sports club, mindfulness, and so on and so forth. Seems to me really important. I visited a school in Herne Bay just before COVID struck, and it was amazing. That head teacher and her team had such an enlightened approach, whether it was running a mile a day, mindfulness after lunch to get the young people back into the room for their afternoon studies, or the fantastic mental health youth ambassadors they had who were trained. And bearing in mind this was a junior school, so they were aged 7 to 11. You know, there were a group of both staff and pupils who'd opted for more training and responsibility to bring about a sort of a whole school approach to mental health and well-being, including physical fitness and the arts and sports. So the mental health support teams should be part of school life, not in any emotional life, not the school emotional life. I mean, that would be overstating their value. I would and they will be best when they're working around the school with as well primary care, social care and other partners. I would just say on the CAMS front, the referrals from mental health support teams in schools, I mean, we were pretty clear from the outset that specialist services should have a role in supervising the team, and that we shouldn't have this referral across to CAMS and then maybe a kind of consideration by the team and a bounce back, that actually CAMS should step into the life of the school and that young person and their family if it was felt that the mental health support teams, you know, wanted to bring in additional expertise. So I think we need to refine that. And finally, on place to be or other counsellors and so on and so forth. I think these are things, so the mental health support teams are really clear about what the training is. As a colleague mentioned earlier, it's a year-long training through university. There's a good evidence base, etc. So that's the route into working in mental health support teams. But of course, other organisations, other roles locally need to be part of the school life in a local area, and it might look slightly different everywhere. The core support team offer will look the same everywhere because of the evidence base, but how it's flexed into the life of the school and the whole school approach should be really designed locally with young people, their families, and other key staff, not by all means, not just the NHS.
Thank you, Claire. Has anybody else got a comment about the preschool element of this? Is anybody doing any work around that?
I was just going to say, Phil, we've done work in Barnardo's across the kind of preschool early years area, whether that be in children's centres, with parents, with the children, young people themselves. We've done play therapy, and we integrate play therapy in quite a lot of our services. So we do take into account the mental health of both parents, carers, and children in their early years. We tend to do things like mindfulness with parents so that they can calm themselves down and regulate themselves without reacting. And we've even done techniques with children with mindfulness as well, butterfly hands and those kinds of things. We use lots of Dr. Karen Treisman's resources for children as well, about understanding trauma and working through it. So I would say we do use a lot of those interventions and support, but as has been pointed out, postnatal depression is very prevalent and needs to be addressed far more readily and far more early in an awful lot of our parents than it actually is. Absolutely.
There was a comment about improving community-based support perinatally, because that will save things further down the line. And you've nicely covered that, and that needs to be part of what we're doing, because we should be dealing with things, as somebody once said, from sperm to worm, so that we really do cover the whole life course of an individual. I want to move on, if I may. There were some questions about how do we accelerate the rollout, and a question about are there plans to roll solar out to other areas, of the Surrey model or the Swindon model out to other areas. How can we have any guidelines for the integration agenda for children's and young people's services? And part of the reason for that is there are huge gaps. One person referred to the gap between those who need services and those who get them being something like 1 to 6. And another person said, how can we prevent our children and young people being let down repeatedly by services? And this is somebody who was a CYP professional as well as a parent, and obviously had experienced huge frustration, which is not uncommon. So taking the fact that there are gaps and frustrations there, how can we accelerate things and take them forward more quickly? Perhaps Liam and Libby, would you come in first on that?
Yeah, absolutely. So as a service, we've been talking about the solar model quite consistently, I'd suggest, for the last 4 or 5 years, in terms of doing things differently. We've gone to various events, whether they are promoted and held by Bernardo's, whether that's through other events in terms of NHS England and other resources. I think what we've always been clear about is that services are best when they're designed on local level of need. So right here in Solihull, what works really well is the integration between Bernardo's, West Midlands and Birmingham Solihull Mental Health Foundation Trust. In other areas, it's down to commissioners and local service providers to do that, coming together to share the resources, where people are already existing with that, established staff teams, established networks, established relationships. They've got buildings, they've got, they are accessible. It's about taking the resources that you've got locally and joining them up with the right skills, expertise, supervision and guidance in something that means that services become more accessible for children and people. From our point of view, we're more than happy to share lessons learned and ways in which we came to the model that we've got and share those across various networks where we can. But I think local providers and commissioners certainly have a role to play in how they develop more integrated services.
Okay, Rickshawn, did you want to say something about the accelerated rollout of things from your experience?
Yes, no, absolutely. So one of the things that we're trying to do as part of our health strategy is to really identify models that work right across our system and to scale those within integrated care systems too. And we will be doing that over the next 12 to 24 months and hopefully working with commissioners to really sort of embed that and work as part of partnership boards within integrated care systems too. So we will be doing a lot of work in this area, so do watch this space.
That's great. Okay, Sarah, did I see you wanted to come in on that? No, you didn't wave at me, that's fine. Fair, I'll give you a chance to have a quick word on this and then we will go on to talk a little bit more about something linked.
Thank you. Just a couple of things. On the perinatal issue, a massive part of the long-term plan is rollout of specialist perinatal services across the country. And 3 years ago, such a low level of coverage across the country existed. Now we've kind of turned the map green and we've got those specialist services everywhere. And this year we've increased the length of time they can work with someone in our capacity modelling from 1 year to 2 years, and they work with mums who are thinking of becoming pregnant all of the way and their families all the way through to 2 years post. We're also rolling out more perinatal and maternity outreach clinics, working differently, and a big part of the role of those teams is to work with the system, whether that's social workers, GPs and others, and train them in perinatal, healthcare as well. So there's a very major programme in Train, which is just lovely and has got more money flowing. On the mental health support teams in schools, we would always like to go further, faster. Come on, we're the NHS. If you give us some money, we'll spend it with our partners and we will go as fast as we can. you have to go through, you have to have the money to pay for it, and the investment, and you have to have the workforce trained to do it. But yeah, very active interest from partners on could we go further faster and what would that take.
Fantastic, thank you, Claire. I'm going to come to Liam and to Sarah for this, because there was a question around co-production, and Liam, you referred to people getting it done in their own area, and it certainly sounded as if, Sarah, you'd done a lot of work on that. Any comments about co-production and what's worked well? Liam?
Yeah, so I think we touched on it at the start. So from the very start of the service, children and people were involved in the design, the naming, the branding, but not just the naming and the branding of the service, but also the model and how it should look. So there was that real-time engagement at the very first point of, we know that we're redesigning emotional and mental health services. We know that we hold this pot of money and resources to provide services to children and young people. Let's engage with young people at that very earliest point and ask them what they want, what works well, what doesn't work well, and having the right people with the right skills to get that out of children, young people and families. So there was lots of stakeholder events, lots of various ways in which young people could feedback based on their specialist skills and knowledge and ability to do so. So whether that was questionnaires and forms through school, whether that was focus groups where they could come and talk, whether that was engaging them in their local communities. It was at that very earliest point, young people. It wasn't, we've come up with a model, we've designed some nice slides that we think might be useful, what do you think? It was, how do we need to run services? And it was at that very earliest point.
Thank you. Sarah?
I mean, we worked with a local organisation that was already working with children and young people in the area, and we integrated parents and pupils into that process. And it was very similar to Liam's, right from the start, right throughout. We were very clear, though, about what could be changed and what couldn't be changed, or what could be influenced and what couldn't be influenced. And I think that's really important throughout the process.
Right. Thank you, Sarah. That's very helpful. I'm going to try and get one more question in, is around access. Do the figures from the Surrey Partnership contribute to the access figures, was one question. Another question was, for Solar, how do you avoid internal referrals and the waiting lists that build up to access specific teams? And are there internal waiting lists to access what somebody needs? And another question about how many of the A&E intenders in your area are known to services. So who would like to start off with that? Sarah, do you want to start? And then we'll come to Liam.
I was going to say, in terms of A&E, I think instances, safeguarding incidents, mental health instances for children and young people are known within the system, but we're a tier 2 lower sort of support service. So unless we're escalating something as safeguarding escalation, we wouldn't necessarily know about. The system knows about it in Swindon, but not necessarily us as a provider.
Okay, Liam, about Solar.
Yeah, so from a crisis numbers point of view, it's hard to put a figure off the top of my head. I'd suggest more than 50% of young people who attend A&E following incident of self-harm or overdose are already known to us as a service.
Okay.
So they have had some support in the past. However, we do take new referrals in that route. And on the internal waiting list, because I know that was another question as well. Of course, we do have internal waits for specific therapies for young persons being identified as needing specialist intervention. For example, if they've experienced some trauma or abuse in their childhood experiences and they're waiting for a specific intervention for that, we do have internal waits for that. The system is structured in a way that what else can we provide in the meantime while that young person waits, so they're not left waiting with nothing, and what other things can we work with the system around, whether that's the support with the school or some anxiety management strategies in the meantime whilst they wait for that specialist intervention.
Thank you, Liam. We are virtually out of time, I'm afraid. Didn't manage to get to all the questions. There's still one or two that were asked, but they're in the chat, and I'm sure you can be in communication after it. I want to say a huge thank you to all of our speakers. Huge thank you to GovConnect and Rob for putting this on. And thank you to all of you for coming and contributing to this. It's been a fascinating time. There's a lot more to be said and even more to be done still. And very best wishes to all of you in the work that you're doing locally, and hopefully this has contributed somewhat to all the things that you're trying to achieve for the next generation who are really part of us here and now. So thank you to everybody and have a good day. Bye all.
Thank you.